Well, hello and welcome to Consensus or Controversy, documenting and discussing investigators' approaches to the management of colorectal cancer. I'm Dr. Tanios Bekaii-Saab, and I'll be moderating the meeting today. This is our faculty for today, Dr. Stacey Cohen, professor at the Hutch, and then Dr. Dasari, professor at MD Anderson. And these are contributing clinical investigators that helped answer some of the surveys that we'll be going through. In preparation for this meeting, Research to Practice conducted a survey of this evening's faculty, as well as 3 additional contributing investigators, Dr. Fakih, Dr. Liu, and Dr. Saeed, which all provided their perspectives on a number of issues related to the management of colorectal cancer. Select results will be discussed during the program. Full results are available to download if interested. And these are the disclosures of each one of the speakers and contributors. This activity is supported by educational grants from Exelixis, GSK, and Natera. Research to Practice, CME Planning Committee members, staff, and reviewers have essentially no relevant financial interest to disclose. This educational activity contains discussions of non-FDA-approved uses of agents and regimens. Please refer to official prescribing information for each product for approved indications. We're going to start with Module 1. And again, we want to thank Dr. Cohen for a last-minute covering a subject for Dr. Sursek, and she will be presenting on current and future role of immune checkpoint inhibition in the management of microsatellite, so MSI-high, dMMR, localized and locally advanced colorectal cancer. So, Stacey.
Thank you for inviting me tonight, and I apologize. You're supposed to be hearing from Dr. Andrea Sursek tonight, who a lot of this data is from her, in addition to her actually making these slides. So I will do my best to represent what she intended to speak tonight, as she had a personal emergency. But with that, I'd like to take it away and really focus on some of the amazing things that have come into play for MSI-high colorectal cancer. So as we think about MSI, that's microsatellite instability. Synonymous to that would be mismatch repair deficiency. And this, as you think about rectal cancer, is about 5 to 10% of rectal cancer. And we know that these cancers are a little bit less sensitive to chemotherapy. So as we've evolved over the years, we know that the total neoadjuvant therapy approach has really become standard. So that's often giving chemo and chemoradiation prior to surgery. But when you look at some of the retrospective data from Memorial Sloan Kettering, when they looked specifically at chemoradiation, they did okay. But these MSI-high cancers tended to progress during the chemotherapy portion of TNT. So our takeaway from that is that this subpopulation not only did worse with what we consider to be standard therapy, we now have new druggable targets that we want to focus on. And so this data has evolved where we're looking at neoadjuvant PD-1 blockade in mismatch repair deficient locally advanced rectal cancer. So the idea is that could we use PD-1 therapy? If we know that chemotherapy doesn't work as well, can we swap out the chemotherapy portion? Could we remove chemo and radiation? Or really the ultimate question, can we go and use just immunotherapy, replacing chemo and radiation and surgery? And so this led to this trial where they evaluated 6 months of durvalumab. It was given every 3 weeks intravenously. And at the end of that time, there was evaluation by radiology and also endoscopic assessment. And so the thought was, okay, if those patients did well, if they had a complete clinical response, they would be able to go on non-operative management, as we would do for an MSS patient who had TNT. But if someone was found to have residual disease after that 6 months of durvalumab, then they would be recommended for chemoradiation and assessing whether they would eventually need to go on to surgery. And so this trial enrolled stage 2 to 3 rectal cancer patients. They used immunohistochemistry for assessing for mismatch repair deficiency and started with a plan for 30 patients, with the primary endpoint looking at overall response rate and also looking at pathologic responses. And so you can take your sort of typical patient who may have a very locally advanced cancer, which is clearly seen both on CT and MRI and endoscopy, And when they started to follow these patients, they noticed that surprisingly, they really had an amazing response. And some of these responses were seen as early as 3 months into treatment, with many patients developing a complete clinical response by 6 months. And this seemed to be not only a development, but a sustained, durable change where they had a complete clinical response that was sustained and did not see a recurrence in those patients. And so now there have been reported 14 patients. And impressively, despite the T-score, the N-score, these patients have shown in this particular study a complete clinical response in all patients, which clearly is something that was unheard of for what we would have seen for, or even expected for immunotherapy, and vastly exceeds what we see for an MSS patient getting TNT. You will also notice that, again, this data is emerging, but really we're seeing longer and longer durability being reported out with an impressive 60 months for some of those early patients, which is 5 years. And really at 5 years of complete clinical response is often when we're saying that maybe that patient is actually cured of their cancer. And again, these patients have not been exposed to chemotherapy, radiation, or surgery. All they had was immunotherapy. So when we look at these patients kind of taking a step back, so we're having more and more patients being treated in this fashion, again, from the MSK group. So looking at a cohort of rectal cancer patients, they were able to see 49 patients developing a complete clinical response, leading to all 49 patients having non-operative management, which is the best waterfall plot that you could hope for, where we're seeing 100% complete clinical response. And I want you to sort of keep this in the back of your mind, because as we'll talk about colon cancer in a minute, we see more impressive responses than we do in rectal cancer, though both are quite exciting. Again, these were durable responses. I'd like you to note that a few patients had a complete clinical response at 3 months. That's those yellow dots. But the majority of the patients, it was on their 6-month assessment, which was at the end of their immunotherapy, and they seemed to have a durable response, with 96% being recurrence-free at 2 years. So this was all MSK data, but this led to the AZURE-1 trial, which is a phase 2 study specifically evaluating dostarlimab in newly diagnosed MSI-high or deficient mismatch repair locally advanced rectal cancer. And the idea here was that, of course, we don't want to just look at a single institution or a single set of physicians treating a cancer population, but rather try to replicate this in a more widespread fashion at a multi-institutional study, and also a larger trial so that we can really look for some interesting signals. And so this rolled 154 patients. They similarly got 6 months of therapy, and they're going to be evaluated. And we don't have the data reported out, but this will be the study that really helps us expand upon what Dr. Sursek had already shown from her own data. Now, as I said, we also need to think about colon cancer, because sometimes colon and rectal cancer behave similarly, but sometimes they have very different responses. So in colon cancer, we expect about 10 to 15% of localized disease to be mismatch repair deficient or MSI high. And in these patients, standardly, we had always said it should be upfront resection followed by adjuvant chemotherapy. And so this was really meant to be for any patient MSI high or microsatellite stable. But again, we know that there is increasing responses to immunotherapy. So this led to the question of, can we treat these patients in a different way? Especially knowing that there is an indication to treat patients across the board with mismatch repair deficiency with immune checkpoint blockade. So the NICHE study was a very interesting study that took localized colon cancer. Now, we don't know if they're stage 1, 2, or 3 because we can't really assess that by CT scan. And they were given 1 month of immunotherapy. On the first day, they got nivolumab and ipilimumab, so PD-1 and CTLA-4 combined blockade. 2 weeks later, a second dose of nivolumab. And then 2 weeks to 4 weeks later after that, they had their surgery. So in this case, in colon cancer, all patients are having a surgical resection, but that also gives us the chance to evaluate the effect of the immunotherapy, because we are now able to see if they actually had a pathologic response. And again, very impressive response here. So when we look at NICHE 2, we can see that patients did very well on this study. And you can see that many of them actually had, as represented in this box here, many of them had a pathologic complete response after just 1 month of therapy. But it wasn't 100%. It was 68% who had a path CR. So we can take away from this that certainly we're seeing that many patients had responses to this drug, but not everyone had a complete either clinical or pathologic response to therapy. However, these patients did very, very well, 100% 3-year disease-free survival. And as we think about the fact that, if this was a stage 1 patient, we expect them to do quite well. But there were probably stage 3 patients in this cohort as well, and we don't expect them to have as good of survival. So the takeaway from niche 2 is that we can get very good outcomes, though we certainly don't totally know maybe what the control arm would have been, since we aren't really able to assess the stage of the disease. But then you might say again, is this true in other patient populations? So this is an example of toripalimab, another PD-1 inhibitor. They did it with or without celecoxib. They gave it for 3 months, so single agent, but 3 months. And so you can see here again a very impressive waterfall plot. And this is a phase 2 study of pembrolizumab. Again, a small study, but really showing impressive responses, but again, not 100% complete clinical response or even 100% path CR. Here we're again seeing about 65%. So we have a lot of responders, but not 100%. So again, we really need to know, is this better than what our standard is before we would start exposing all patients to this regimen? So that led to the AZURE-2 trial, a phase 3 study randomizing perioperative dostarlimab, perioperative because they would get 4 cycles before surgery and 6 cycles after surgery, but never have chemotherapy, or what would be considered standard of care, which is surgery followed by adjuvant chemotherapy for 3 to 6 months, or could be recommended for observation if that was the recommendation of the provider. And so this will be very interesting because this will really question, is immunotherapy in the neoadjuvant setting going to be a more helpful outcome? But of course, as we're going to talk about, some of the standard of cares have changed. So even if this is a positive study, it's going to be tricky to integrate it into what we know now for standard of care. Specifically, standard of care for adjuvant therapy of stage 3 cancer has now changed. This is as of ASCO 2025. So in this ATOMIC trial, it was stage 3 or node-positive patients after surgical resection, again, only MSI-high disease. They could have 1 cycle of FOLFOX while that was being assessed. But effectively, they were randomized to FOLFOX alone for 6 months, which was the standard of care at the time, versus FOLFOX plus a year of atezolizumab. And again, keep in mind that many patients now get 3 months of chemotherapy because we have changed based on the IDEA trial. But this is really asking the question, is chemoimmunotherapy better than chemotherapy? With again, the caveat that we're using a PD-L1 inhibitor here, which maybe has slightly different efficacy. As reported out in the New England Journal, we do see an improved disease-free survival from adjuvant atezolizumab and FOLFOX versus FOLFOX alone. Here we're seeing a 3-year disease-free survival of 86%. Keep in mind, niche was 100%, but also may have had some earlier stage disease. So we have to sort of put this all into perspective that standard of care is ever-changing, but at the same time, we have some really exciting options, making it very critically important to know the MSI status of your patient. So what about non-operative management, though? We said we have no problem doing this in rectal cancer. We can monitor them closely with MRIs and endoscopy, but it's a lot trickier in colon cancer, where we don't have the ability to do a colonoscopy every 3 months, and our CT imaging might not be quite as sensitive. So could we think about non-operative management, especially knowing that maybe 2/3 of patients had a path CR, so maybe we're resecting more patients than we should. So could we think about this if we knew that they had a clinical complete response? And really we need to know about the durability of that response, but also understand who isn't responding, who's likely to recur before we start scaling back from curative intent therapy. So as we've looked at some of the data that's been presented so far, again, coming from the MSK group, they have evaluated dostarlimab across the board in locally advanced mismatch repair deficient solid tumors, similar design, 6 months of dostarlimab, and then if they have a complete clinical response, considering for non-operative management, versus if they have residual disease going on to additional therapy. This is the characteristics. So we are here to talk about colorectal cancer. You can see colon in light blue, rectal in dark blue, but there was about 1/3 that had other cancer types as well. I also want to mention that this was done by immunohistochemistry, which can sometimes have some false positives. So as we think about immunotherapy trials, we have to remember that without central confirmation or MSI by NGS, there could be some MSS patients that sneak in here. But effectively, 124 patients were enrolled, 103 went on to have treatment, and so we'll talk about sort of the rectal and non-rectal cohorts. For non-rectal, it was 54 patients. 35 had a complete clinical response, and 19 had incomplete response. 2 of the ones with complete clinical response still had surgery, but the majority had non-operative management. On the flip side of the incomplete responders, a couple of them actually had non-operative management by their own choice, but the majority of them had surgery. So as we look at colon cancer, 82% had a clinical complete response, but again, not 100%, so not as good as our rectal data. And then when you look at the 4 patients who had surgery, 1 had a pathologic complete response, but 3 of them still had residual disease. So I think our takeaway from this is that colon is not rectal cancer, and we still see very good responses, but maybe not enough to just stop doing surgery on this patient population, but definitely something worth more study. But like rectal cancer, when patients respond, they do seem to have durable responses, 85% recurrence-free at 2 years. This is heterogeneous across a number of cancers, but still a high number is great. And what we're seeing here is that for MSI-high colon cancer, we are seeing, again, 2/3 or so have a complete pathologic response. In the studies that have been presented, there's been variable amounts of immunotherapy that have been given, anywhere from 1 month in niche all the way up to 6 months. And so maybe that's influencing some of those outcomes. So looking across the board at the published studies, on the x-axis here, we have duration of treatment, so going from 0 to 6 months effectively. What you see there is that for the longer duration of treatment, we're actually seeing a higher complete response rate. And what we don't know from that is, is it the amount of time? Do we just need to give the immunotherapy and wait a little bit longer to see the response? Or is it that we need to be continued on immune checkpoint blockade? Or maybe we need to be doing dual, like PD-1, CTLA-4. So I think there's still some things that we're figuring out, but certainly very exciting area of interest. But again, this is going to rely heavily on endoscopic exams because we know that we can't see this on CT imaging alone, doing biopsies and evaluating what the residual disease is, because make sure that, again, we really do have an MSI-high tumor and we're not mistakenly treating something that's microsatellite stable. So in conclusion, further workup in how we evaluate clinical complete response really needs to be done, but neoadjuvant PD-1 blockade and mismatch repair deficient or MSI-high tumors really is changing how we treat colorectal cancer for localized disease. It could potentially replace chemotherapy, radiation, and surgery. We can use ctDNA, which Dr. Dasari is going to talk more about assessing for response, and that maybe help guide us for some of these patients. And then we really need to figure out, if we're going to do this, how do we do it correctly? What's the right duration? What's the right combination? And how do we evaluate that response? Thank you.
Well, thank you, Stacey. All right, so thank you. That was a wonderful and great summary about the evolving landscape. So first, we're going to start with a survey that went to, again, the 3 of us and the 3 other contributing faculty. Mostly about testing method generally used to assess MSI, MMR status in localized colorectal cancer. And Stacey, I know you touched upon tissue versus liquid. So everyone seems to favor tissue testing. My question to you is there an instance where if tissue is not readily available or others, do you rely on liquid, on ctDNA assessment for MSI?
I personally rely on tissue testing the most and would use liquid biopsy in the setting of metastatic disease when you're trying to get a rapid answer and you're doing a quick screen. Or I guess in localized disease, if maybe you had a very small sample, if it's rectal, you could rebiopsy, but if it's colon, you might not be able to rebiopsy, and you don't have enough invasive adenocarcinoma to do that assessment. The problem is that a smaller localized tumor might not shed that much by liquid biopsy, so I would be concerned that you would be still getting false information if you did liquid biopsy alone. So I would really preferably still rely on tissue testing.
So tissue preferable, ctDNA only if tissue is not available. So then the next question that the survey question was, which assays do you employ to assess essentially MSI, MMR in localized CRC? And you can see again IHC for the most, but next generation sequencing as possible added alternative. Arvind, you said IHC, you didn't include next generation sequencing. So any thoughts?
So my intent here was to just comment on the initial tests that we probably would do. Tissue is available, IHC has a quick turnaround. So that would be the test I'd order, but completely agree that NGS can also be done. And in fact, I'd argue that it should be done now with all the data we have with regards to PIK3CA and other information that's helpful for localized CRC.
So Stacey, you said mainly NGS versus, Arvind think mainly IHC. What differentiates in your mind NGS from IHC as a preferred modality?
I see a lot of referrals that have IHC being done in the community, and so for us, we would then be ordering NGS sort of for confirmation. And I think one thing that NGS really adds that IHC lacks is the ability to get a tumor mutation burden, which could screen for some of those ultra-hypermutated tumors that are more likely to respond to immunotherapy and would be missed on IHC since they tend to be MSS. But I would say my lab medicine colleagues really feel that NGS is the gold standard, and so that's sort of what we've done. We've tried to implement a reflex strategy for IHC because I agree it comes back faster and I want that information. I will say we've been somewhat unsuccessful. So that's why I give you a hedged answer.
Okay, so another survey question related to regulatory reimbursement issues aside, what would you most likely recommend as neoadjuvant therapy for a 65-year-old patient with MSI-High, so dMMR, locally advanced rectal cancer? And so dostarlimab seems to be preferred for the most, a couple of pembrolizumab sprinkled in there. Any preference, Arvind, you said dostarlimab. Any thoughts about using other PD-1, PD-L1 inhibitors?
Yeah, I'm not sure if we have head-to-head data that would say that one PD-1, PD-L1 agent is significantly better than the others. So I think any of the agents are reasonable. So I suspect why the majority chose dostarlimab is the data were generated using this drug. So that perhaps was driving it, but I'd be comfortable using pembro as well.
Okay. So Stacey, have you exclusively used dostarlimab in this setting?
No, I've used other PD-1 inhibitors, and I would say that I have personally not experienced 100% complete clinical response rate. So when the data was just first coming out and I was unable to get dostarlimab sometimes from insurance and I wasn't getting a response in every patient, one of the things I question is it the drug? So if I have to pick any drug, now I'd pick dostarlimab just in case that is the cause, though I think we may see in some of the future larger trials, it's not 100% in general outside of MSK's data. So I do it mostly just having to choose a drug, but I think any PD-1 inhibitor I'd be comfortable with. I'd be less comfortable with a PD-L1.
Got it. So the next question was, in which clinical situations are you currently administering an immune checkpoint inhibitor as a component of neoadjuvant therapy for a patient with MSI-High dMMR, early stage rectal cancer? Quite a bit of concordance and discordance in some of the answers. So Arvind, you said any patient being considered for neoadjuvant therapy. Can you elaborate further on that?
Yeah, I mean, I guess I was just trying to word it a little differently, but completely agree. I mean, any patient who is MSI high and rectal cancer, early stage rectal cancer, can get immunotherapy unless it's one of those rare situations, just a tiny malignant polyp that you can just take out.
So Stacey, Anwar put in stage 2 and stage 3, I guess, excluding stage 1. Is that a reasonable assessment? Would you consider a stage 1 for immune checkpoint inhibitor, rectal cancer?
I think any stage 1 patient who could not be treated, as you proposed, in a polypectomy, I would give immunotherapy preferably over an oncologic surgery.
Okay. So the next survey question is, regulatory and reimbursement issues aside, what would you most likely recommend as neoadjuvant therapy for a 65-year-old patient with MSI high, dMMR, locally advanced colon cancer? So Arvind, you said none. Most everyone suggests, except myself. Actually, we agreed on this one, except we disagreed with everyone else, I guess. So maybe elaborate a little further. Why none?
Yeah, so definitely not opposed to doing immunotherapy in patients with locally advanced colon cancer, preferably on a clinical trial. As Stacey very nicely outlined in her presentation, there are still a few unanswered questions. How do we monitor clinical response in these patients? How often do we do colonoscopies, which are really not that comfortable for patients? How reliable is ctDNA and imaging in colon cancer patients? And are responses truly durable? So waiting for those questions to be answered. So preferably should be done on a clinical trial, but the data so far are really compelling. So if the patient really wants to do it, I would not be opposed.
So Stacey, very quickly, I mean, unlike Chris Liu, you go for the whole thing. For Nivo-Ipi, he favors pembrolizumab. Any thoughts about adding the CTLA-4 inhibitor? Is it needed?
I mean, I think the niche 2 data is very compelling with a short duration of therapy, not a long delay to surgery, and then a 100% disease-free survival at 3 years in a small study. So I find that to be compelling enough that I recommend nivolumab, ipilimumab, but I agree, Arvind, I don't do this on every patient. So in a straightforward colon resection, small tumor, we will take them straight to surgery. If there's anything that's complicated, we recommend immunotherapy. So, and I think among the patients who are recommended straight for surgery, we'll have a discussion about immunotherapy. It also depends on, is this patient a germline Lynch syndrome patient or a somatic MSI? Because a Lynch syndrome patient may be electing for a more extensive operation, maybe even a risk-reducing gynecologic operation or something of the sort. And so with that in mind, there may be a reason to do surgery rather than immunotherapy as well.
Okay, thank you. So the next survey question was, regulatory and reimbursement issues aside, what would you most likely recommend for a 65-year-old patient with MSI high dMMR? Now, this is a stage 3 rectal cancer who receives 6 months of neoadjuvant dostarlimab and achieves a complete clinical response. So Arvind, you favor observation.
Yeah, non-operative management, I think, would be reasonable in these patients, just given the sustained responses we've seen in the data so far. And also, the rectum is something that we can surveil with reasonable confidence with MRIs and endoscopies and digital exams.
So Stacey, you and Anwar seem to be the only ones who favor surgical resection followed by observation.
I'm going to redact my answer on the basis I did this at 11 o'clock last night and probably didn't read the question carefully enough. I would do observation as well.
Okay, got it. So we'll leave Dr. Saeed on her own on this one. Okay, gotcha. So regulatory and reimbursement issues aside, what would you most likely recommend for a 65-year-old dMMR? Now, same scenario, but the patient does not achieve a complete clinical response. So Arvind, he said, discussion on chemotherapy and radiation followed by surgery. Pretty much you're the only one who would consider chemoradiation out of the group here. Why is that?
I mean, I was really going back and forth on this answer. So there are several options. As we've seen, some patients have not had CCR by 6 months. If you do continue immunotherapy, they may get CCR a little while later, 9 months or beyond. So continuing immunotherapy, I think, is a very good choice. And also, how should that immunotherapy be? Do you escalate it to dual checkpoint inhibitor at that point? Is another thing that I was thinking about. But all the trials that were designed initially did have the option of kind of chemoradiation if they've not had a complete response. And I believe that this should be a discussion in a multidisciplinary fashion to make a decision. For instance, if it is a T4B tumor that's really not budged, perhaps that would be a situation where you want to change directions and do chemoradiation versus another tumor where it went from, say, T3 to T2 or T1, and you could push it a little more with more immunotherapy.
Okay. So a 65-year-old patient presents now with high-risk stage 2 MSI-high dMMR colon cancer and undergoes an R0 resection. Regulatory and reimbursement issues aside, what would be your preferred approach to adjuvant therapy? So Stacey, you said for many would observe those with T4, so high risk, would discuss option of FOLFOX, CAPOX plus atezolizumab.
So I think we have to be careful when we look at high-risk stage 2 and recognize that there's a lot of different features that make a high-risk patient, one of which could be poor differentiation, which is just a typical finding for an MSI-high tumor. So I think in stage 2, you really need to be careful about what is sort of a pathologic, sort of typical feature for an MSI-high tumor and what is something that you maybe need to react more to. And I would say among the risk factors, really T4 is the major one that I would consider to be a true high-risk stage 2. And so in those patients, I would consider giving them chemoimmunotherapy in the adjuvant setting. But even with T4, I think you can sometimes differentiate it. If it's T4 that is, invading into the uterus and you remove the uterus, that might be less concerning than T4 invading into the pelvic sidewall where you're not sure that you had a good margin. And so I think it kind of comes down to how aggressive does the patient want to be, but I think you could at least consider it in those like really high risk stage 2.
And Arvind, you favor observation, except again, you agree with Stacey relatively on the T4Bs, but you also include MRD positive, and I know you're going to talk a little bit about that, so we'll look forward to your discussion then. So a 65-year-old patient presents with stage 3 now, colon cancer, MSI-high dMMR, and undergoes R0 resection. Regulatory and reimbursement issues aside, what would be your preferred approach to adjuvant therapy? Arvind, you said FOLFOX, CAPOX plus atezolizumab. Let me ask you this. Would you favor CAPOX? So I in my answer was CAPOX 3 months, and I had plus minus because the question is, do we really need chemotherapy for those patients? And if so, would you favor FOLFOX or CAPOX, and what would be the duration?
Yeah, a great question. I guess we're trying to merge data from IDEA and ATOMIC, so kind of extrapolating 3 months of CAPOX from IDEA and adding on immunotherapy from the ATOMIC trial. So given that these patients overall tend to be at a lower risk of recurrence, I do think that 3 months of CAPOX plus atezolizumab would be reasonable to do.
Stacey, would you skip chemotherapy altogether?
I'm not quite comfortable with that. I think if we look at the COMMIT trial, which was first line and had chemoimmunotherapy and also had the atezolizumab own arm, it didn't really do as well as PD-1 inhibitors. So I'd be a bit hesitant in the adjuvant setting about treating with a PD-L1 inhibitor by itself.
Okay, thank you. All right, Arvind, you're next with clinical relevance, practical utilization of molecular residual disease, MRD analysis in colorectal cancer. Please.
Thank you very much for this opportunity. And so these are my key takeaway points from today's talk. As you all know and have probably used, MRD assays are available for clinical use in the US. That's unique compared to other countries because it's approved by CMS for reimbursement, and that's really provided us with a unique opportunity to generate a lot of data from observational cohorts, prospective, to really establish the strong prognostic implications of MRD assays. But what we really need are these prospective randomized interventional trials to truly establish these as validated biomarkers. And these trials are ongoing. And these trials, again, because these assays are already being used in clinical practice, provide a unique opportunity to really integrate research and clinical practice. So starting with some basic background, as you all know, the way we do adjuvant therapy currently is suboptimal. Taking the example of stage 3 colon cancer, the guidelines currently say all stage 3 colon cancer patients need to be treated with adjuvant chemotherapy. But in reality, only a proportion of these patients, perhaps 20 to 25%, actually benefit from the adjuvant therapy, with the rest either not needing it or not benefiting from it. But we are causing toxicities for all of these patients. So what's really missing is that kind of what I like to call the sorting hat from Harry Potter, where you can really say who's at the highest risk of developing recurrence so that those patients can get adjuvant chemotherapy and perhaps even escalate adjuvant chemotherapy beyond what we currently do through clinical trials. Or in patients who are MRD negative and lower risk, kind of de-escalate adjuvant chemotherapy. And that's where the promise of these MRD assays is, to really provide that strong, reliable prognostic information. And we certainly have compelling data from observational cohorts. These are large, prospective, independent observational cohorts that all show the same key conclusions. Firstly, that MRD is very strongly prognostic for recurrence after surgery. So if you're MRD positive, the risk of recurrence is very high compared to MRD negative, with hazard ratios in double digits, so 10 to 20, depending on which cohort you look at. And also, if patients are MRD negative, on the flip side, recurrence risk is really low, and it really doesn't appear to matter whether patients have received adjuvant chemotherapy or not, suggesting that these patients really do not need adjuvant chemotherapy. As you can see, the disease-free survival with and without adjuvant chemotherapy is very, very high, touching 90%. And finally, in patients who are MRD positive and are at the highest risk of recurrence, although by doing adjuvant chemotherapy, we are improving outcomes. For instance, we are improving the disease-free survival from less than 5 to 10% to 30 to 40%, depending on which cohort you look at. It's still much lesser than the 90% we're looking at in patients who are MRD negative. So we need better adjuvant therapies for these patients. So these compelling observational data really prove the clinical validity of these MRD assays, in that we're able to use these assays to determine the outcomes of patients based on the results. But what we really need are data from prospective studies so that we know exactly what to do with this data. So all we can say right now reliably is, well, the patient is at a higher risk or a lower risk of recurrence, but how can we use that information to make clinical decisions? And there are data rolling in from randomized studies. This is a phase 3 trial, the Dynamic 2 trial led by the Australian group, that asked the question, can we use ctDNA information or MRD information in patients with stage 2 colon cancer after surgery to reliably make decisions about de-escalation of therapy or escalation of therapy based on the results. And this is a non-inferiority trial. And indeed, ctDNA-guided approach was non-inferior to standard of care. And what was really compelling is that the ctDNA-guided approach actually reduced the proportion of patients who were getting adjuvant therapy. So we gave adjuvant chemotherapy to fewer patients, but did not impact their long-term outcomes in terms of risk of recurrence. They then asked the same question in patients with stage 3 colon cancer. So patients with stage 3 colon cancer after resection were evaluated with a tumor-informed assay and were placed in one of two groups. One was ctDNA-informed management. The other was the control group of standard management. So in the ctDNA-informed management, if patients were ctDNA positive, then adjuvant chemotherapy would be escalated. And this is not uniform. This was kind of pre-planned but left to the investigators. Overall, it did appear that the ctDNA-informed escalation was really not superior to standard management. And then looking at the de-escalation cohort, again, the same question. Based on the ctDNA information, can we de-escalate therapy for these patients in the adjuvant setting? Again, this is pre-planned, but left to the investigators to decide. The non-inferiority could not be proven for patients who underwent the ctDNA-guided approach. But the thing to remember is that this was a trial that was done with an older version of the assays. Kudos to the group for being so farsighted in launching this trial, but this was done with one of the older assays, and also the decisions about escalation and de-escalation of adjuvant chemotherapy were not kind of determined in the protocol. They were left to the investigators. So we do need to enroll patients onto ongoing clinical trials, such as Circulate North America, the ongoing trial in the US and Canada, that is trying to answer these questions for high-risk stage 2 and stage 3 colon cancer patients. So far, we've talked about trying to make decisions about adjuvant chemotherapy for patients after surgery. But how about kind of using ctDNA during surveillance? So these are patients who finished curative intent treatment and are undergoing surveillance, and we're doing ctDNA-based MRD testing in these patients. What we know so far is that in these patients, when the ctDNA comes back positive, there appears to be a lead time, with a median lead time of about 6 to 9 months between the assay turning positive and there appearing disease on scan. So could we intervene during this time to prevent these inevitable recurrences from happening? Because almost everybody tends to develop a recurrence if left untreated, with a positive predictive value approaching 100%. So these are compelling data from the CALGB 80702 trial. Just to refresh your memory, this was one of the trials that went into the IDEA consortium that asked the question of 3 versus 6 months of adjuvant chemotherapy. So this was the North American trial contributing to that pooled analysis. This also asked a separate question of the effect of celecoxib when added onto adjuvant chemotherapy. Would that improve outcomes as well? So that was another question that was asked with this trial. In the initial analysis, as you can see in all comers, there did not appear to be a significant benefit with the addition of celecoxib to adjuvant chemotherapy, although there appeared to be a hint of benefit with a hazard ratio of 0.9. But when the investigators went back and looked at the retrospective plasma samples, what they found was really, really striking and really, really compelling. In patients who are ctDNA negative, whether you added celecoxib or not, it really didn't matter because they were really doing so well no matter what, because they were at a really low risk of recurrence. But in the patients who are ctDNA positive, what they found was that the addition of celecoxib really provided a significant protective benefit with a hazard ratio of 0.55, which is really remarkable. I mean, that's much more than what we would see with the addition of oxaliplatin in the older adjuvant trials. Now, granted, this is a retrospective analysis that was post hoc, but there are prospective trials that were done, including the Circulate Japan-based Altair trial, where patients who are ctDNA positive during surveillance were randomized to observation versus TAS-102 if and when they turned ctDNA positive during surveillance. And overall, there did appear to be an improvement in disease-free survival, but as you can see, long-term outcomes really did not change between the two groups. But nevertheless, this is a proof of concept study showing that we can do trials in this space successfully, and there are several ongoing trials in this space currently, including these 2 large trials here in North America. And at this meeting, we'll have more data being presented, kind of really cementing the role of ctDNA in this space. Another analysis from the Japanese Galaxy study showing that addition of adjuvant chemotherapy, even if you don't start it immediately, if patients turn ctDNA positive later on, still improves their outcomes. And then a late-breaking abstract of the German Circle-8 trial looking at ctDNA-guided approach in stage 2 colon cancer patients. So these are compelling data we're all looking forward to. Okay. And I'll stop there. Thank you very much.
Thank you, Arvind. Great, really good summary for a field that continues to evolve. So we'll go again through some of the survey that went to us and 3 others. Outside of a clinical trial setting, to what extent do you use ctDNA MRD testing in the following scenarios? So resected stage 2 colon cancer with no high-risk features, resected stage 2 colon cancer with high-risk feature. There seems to be a little bit more of an agreement when there are high-risk features, a little bit less so with no high-risk features. Stacey, you say usually or always. How do you decide? I mean, usually versus always.
I think, it's important still to discuss ctDNA testing with your patient. It's not considered to be, guideline-approved testing at this point. And so I think that's the difference to me between usually or always. But I talk to my patients about getting a potential, additional blood test that can help risk stratify. And I do think that patients, even with low-risk stage 2 disease, if you agree with the test and it comes back positive, I'd be very concerned about the recurrence risk of those patients. And so I think of it sort of irrespective of the pathologic features because, again, those are a snapshot in time from the pathology specimen, but I think that we can learn a lot about the dynamic marker that is ctDNA.
So, Arvind, given the pretest probability is relatively low in the no high-risk features, how do you feel about your answer with usually always versus, let's say, what Dr. Liu or Dr. Saeed, or Chris, or Anwar said commonly or occasionally?
Yeah, completely agree with what Stacey outlined, a conversation with the patient and before ordering the test. In our practice, you'll see a spectrum of answers as you've seen here, but in our group, we just test pretty much everybody, and that's the reason I said usually or always. I think we're one end of the bell curve.
Okay, so you do it universally, yeah. And for the stage 2 colon cancer with high-risk features, you see most everyone would do it usually always or commonly within range, so there's quite a bit of agreement there. So outside of a clinical trial setting, to what extent do you use ctDNA-based MRD testing in the following scenarios? So we have a resected stage 3 colon cancer with low-risk features. Here, there's a little bit of a closer agreement. And then resected stage 3 colon cancer with high-risk features, same thing, although the 2 of you are a little bit more on the always side, so a little, more universal than any. So, Stacey, I'll have you discuss this first. So, choice of usually always versus commonly.
I think you could argue that stage 3, there's more equipoise about whether or not to give chemotherapy, so there's a bigger role for adding an additional risk factor, whereas effectively you're going to recommend all stage 3 patients to have adjuvant therapy at this point, and so until Circulate North America is out and we see, but at the same time, your pretest probability for these patients is much higher, and so maybe using a test that can add to that is helpful. I think the way that you can use ctDNA in this setting is not a go, no-go for chemotherapy until we have that trial, but maybe to think about the duration or dose intensity of your chemotherapy and having more confidence if you need to push someone through a little longer or maybe feel more comfortable stopping a little earlier if someone's having toxicity.
So, Arvind, for the high-risk patients, how would that change your, your management, say, for a positive?
Yeah, for a patient with I guess, either stage 2 or stage 3, if they're ctDNA positive, I mean, in my mind, that's probably a higher risk of recurrence than any other histopathological features. So I would want to maximize adjuvant chemotherapy. Try to push for 6 months of therapy. As
6 months of K-Pox?
I would certainly discuss that with the patient, try to do as much as we can, because we do know that patients who are ctDNA positive and then turn ctDNA negative with adjuvant chemotherapy have much better outcomes than the alternative.
Stacey, what would you do?
I think so, and I would just add in that I would also image them more frequently than I might for someone who's ctDNA negative. So when they come back positive, maybe they had a scan 1 month before surgery and you didn't re-image them after surgery, but if they came back positive, that would prompt me to get a scan. And if they were persistently positive, I might re-image them partway through because maybe they are progressing on adjuvant therapy. And if you have a ctDNA assay where you can look at the quantification, you could also sort of be starting to assess if you feel like that is decreasing or increasing to look at the utility of your therapy as well.
So you use it for assessment of response. I mean, technically here you're not really reading response, but understood.
Yeah.
Okay. Outside of a clinical trial setting, to what extent do you use ctDNA-based MRD testing in the following scenarios? So interestingly, for resected oligometastatic disease, there's actually a lot more of agreement with usually or always. And so let's start with this first. And, Anwar, Dr. Saeed went with commonly, so a little bit more on the more conservative side. So Arvind, is this a setting where you think there's quite a bit of utility? Of utility, not futility, of utility in this setting?
I would think so. As Stacey outlined, I mean, kind of looking at the pretest probability, certainly these would be the patients at kind of the higher end of the spectrum in terms of the risk of recurrence. So it'd be very helpful to know and monitor these patients closely for recurrence. Also, increasingly, as we've seen, there are clinical trials being designed for these patients that we could consider as well if and when they turn ctDNA positive.
So for localized rectal cancer, there's mostly commonly, occasionally, and then Arvind, usually or always. Stacey, you're on the commonly, meaning, you do it frequently, but not usually or always. So tell me a little bit more about your line of thinking with localized rectal cancer and the use of MRD testing.
So I interpreted this to mean, would you test in the neoadjuvant setting, which I don't know if that's what the question was asking exactly, but in the post-surgical setting, I would commonly test. But in the neoadjuvant setting, I think also has some role because there is data suggesting that responses in the neoadjuvant setting may suggest whether or not that patient actually has a complete clinical response. So we talked about using endoscopy and imaging to be able to tell if someone had a complete clinical response. But I think if you then had what appeared to be a clinical CR, but they had a ctDNA positive, that would argue to me that maybe they didn't have a clinical CR and they might need to undergo surgery. So I think in that setting, we're learning how we can use that more, but it's, to me, another area of potential interest.
So Arvind, very quickly, would you use it in the more adjuvant setting or neoadjuvant setting?
Yeah, the role of ctDNA certainly in the neoadjuvant setting is rapidly emerging, not firmly established. So it's helpful to figure out what the response is looking like, but certainly would do it in the adjuvant setting.
Okay, great, thank you. So next is outside of a clinical trial, would you be comfortable omitting or de-escalating adjuvant systemic therapy on the basis of now negative ctDNA, so negative MRD result alone for, and we'll fill in the blanks. This is a stage 2 colorectal cancer with high-risk features. So a younger patient, so less than 65. Everyone said no except for Marwan. He says yes. Stacey, any thoughts?
I mean,
would there be a scenario where you would consider this?
Sure. I mean, I think in the older patient where it's described, 85-year-old.
Well, we're going to discuss the older.
Right, but I'm saying I think in that setting, you're looking for an excuse not to give someone chemotherapy. So if you had a negative ctDNA, you'd feel more comfortable. I think in the younger, presumably fit 65-year-old, you're still concerned about the potential outcomes for that patient. And I think having, high-risk features is not totally determined how that patient's going to do by ctDNA alone, just based on some of the data that we have. So if that person, I would recommend it, and if they said they don't want to go on chemotherapy, I'd feel much better in the setting of ctDNA negativity. But I would still, at this point, for a patient who I think needs chemotherapy, I still recommend chemotherapy.
So Arvind, since the pretest probability here is high risk, and how comfortable are you with the level of sensitivity that would predict a true negative result that will allow you to take that decision?
Yeah, the current generation of assays are probably a single time point assessment sensitivity of probably around 60%, 50 to 60%, but that does increase with serial monitoring. But for this patient, I think the sensitivity probably would be around 50 to 60%.
So I think everyone agrees on the older patients. Now, if you were to use a serial have you employed or would you employ MRD testing to monitor for response to adjuvant therapy in patients with localized colorectal cancer? So, Stacey, you said I have, and it seems like pretty much everyone has. So, what scenario would you use it in?
I mean, I think, we talk about in a binary fashion of MRD positive or negative, but as Arvind said, we can also use this longitudinally. So I don't necessarily, if someone's positive and they convert to negative, I don't consider them cured per se, because it could be a false negative on therapy. But I do surveillance testing for 2 years at this point, and so I would consider that part of that a response to adjuvant therapy.
How about you, Arvind?
Yeah, completely agree.
For every patient?
So like I said, we're probably one end of the bell curve in that we test everybody. So,
can you think of a scenario where you wouldn't do it?
There are patients who do not want to know this information. So this would be always based on a discussion with the patient.
Okay. Now, a 65-year-old patient presents with microsatellite stable stage 2 colorectal cancer with no colon cancer, with no high-risk features, and undergoes a R0 resection. So that's a colon cancer. What would be your approach to adjuvant therapy? So Stacey, you said observation. This is an MSS stage 2 colon cancer, no high-risk features, undergoes R0 resection.
Yeah, I think in the world without ctDNA testing, that would be standard of care, would be observation for a stage 2.
Do you agree with Arvind that if MRD is positive, you would offer FOLFOX, CAPOX?
I would. I think what we can take away from the dynamic trial is that when patients are positive, they are at very high risk, and I agree that I would typically do a doublet in that setting. Okay,
do we think it changes outcome, Arvind?
Yeah,
meaning survival?
Yeah, we have seen compelling data that a proportion of patients can have their ctDNA cleared and their outcomes can improve with adjuvant chemotherapy when they're ctDNA positive. Okay. So, yeah.
Now, a 65-year-old patient presents with MSS stage 2 colorectal cancer, no high-risk features, undergo R0 resection, ctDNA ordered, and they're positive. I think you guys have already discussed this one, so we're going to skip this one and jump to the...
I'm going to blame the late night on that one. That's FOLFOX, CAPOX for me.
So a 65-year-old patient with MSS, okay. So you would say FOLFOX, CAPOX. We have a couple minutes actually to get a couple of questions in. And we're going to go back a little bit to the previous discussion. So in your dMMR resectable colon cancer, Stacey, should we do neoadjuvant IO therapy prior to surgery, or do you think adjuvant chemoimmuno? Which strategy would you favor?
I think we do both. I think it depends on the patient, the bulkiness of the tumor, so how easily or hard it is to resect. As I said, if they need other surgical management, for prevention, for Lynch syndrome. I think all of that's taken into consideration. And I would offer both strategies to the patient. Some people want to have their surgery right away, and they would rather avoid all systemic therapy if possible. And there's patients where you sort of have an inkling that they are going to have more high-risk disease, and so I would really try to give them immunotherapy to avoid chemotherapy exposure. But we have to keep in mind, I didn't really go over toxicity, but these drugs are not without toxicity, and so we have to be mindful of that, a right hemicolectomy could be a relatively easy to tolerate surgery. Immunotherapy could be an easy to tolerate systemic treatment, but it's not true for every patient.
So Arvind, very quickly, are you ordering next-generation sequencing on tissue for all colon cancer stage 2 and above?
Yes, I would at this point.
Yeah. And why is that?
In addition to the MSI testing, we have compelling data that patients with PIK3CA mutations benefit from aspirin therapy. And the only way to find that out is by doing sequencing.
Okay, thank you. All right, now we'll move on to the next module, recent advances in metastatic colorectal cancer, optimizing immune therapy and other approaches. I'll be presenting this. So as we know, actionable colorectal cancer targets in 2026 have become quite a few, from MSI-High to BRAF V600E mutations, HER2 amplifications, RAS G12C, and other RASs, and there's quite a few other biomarkers. So this is looking very different from 2012. So in 14 years, we've pretty much, started slicing this disease into all these subgroups. So focusing on MSI-High colorectal cancer first, and this is metastatic colorectal cancer. Our first study was KEYNOTE-177, which looked at in the first-line setting, pembrolizumab versus chemotherapy. Now, this study, just to put in context when we moved to Checkmate 8HW, did not centrally confirm patients for MSI-High. We know about 15% of the patients, which we see in Checkmate 8HW, are either unconfirmed or end up being actually microsatellite stable and did not need or would not need immune-based therapy or PD-1 inhibitors. Checkmate 8HW was designed to answer multiple questions, actually. One is the addition of a CTLA-4 inhibitor, IPI in this case, to Nivo, improve outcome over chemotherapy? And then would it improve outcome versus Nivo alone? So is there an added benefit for adding that CTLA-4 inhibitor? And this was actually across multiple lines of therapy, not just first line. There were about half of the patients, I think, that were first line. The others were multiple lines. So initially, the results looked pretty impressive. Now, again, as a reminder, this was for 85% of the patients that were enrolled and that were confirmed. So they excluded those 15% from the analysis. So Nivo-Ipi certainly did better than chemo, not surprising. Then when looking at Nivo-Ipi versus Nivo, and that's across all lines of therapy, there was certainly an improvement with the addition of the CTLA-4. It certainly is meaningful, but those lines are not too far apart. But then when it comes actually to looking at the first line, MSI-High metastatic colorectal cancer, the response rate was higher, and PFS was numerically higher, but it did not meet statistical significance, with a caveat that that was not necessarily powered for that. So that certainly brings the question about, is IPI needed for all patients to be added to Nivo versus Nivo alone, or versus PD-1 alone, especially the fact that it adds significant cost and certainly adds significant toxicities. And we can see that about quite a few patients had to drop because of severe toxicities. And I think that's important to keep in mind. The other piece in this disease is about when you think about MSI-High patients, about 20 to 30% of them will have BRAF V600E mutation. And traditionally, we've certainly prioritized a PD-1 inhibitor, now preferably actually a doublet for those patients because they tend to do worse. They tend to be less responsive to single agent. So the question is, of course, do you target, do do you essentially use immunotherapy and target BRAF V600E at the same time? CMARC, a large phase 2 randomized study, actually is addressing this, completed and looking at Encositux pembrolizumab versus pembrolizumab primary endpoint PFS. Hopefully, we'll see those results in the near future, because the question of sequencing versus putting IO plus Encositux to improve outcome of this subgroup of patients is quite relevant. So, of course, after seeing all these advances in MSI-high, the question is, can we bring immunotherapy into essentially microsatellite stable metastatic colorectal cancer? And there have been multiple attempts and continue to be multiple attempts to certainly try to improve the activity, the immune responsiveness of patients with microsatellite stable. We certainly know that, for example, the non-liver metastases may have a more favorable immune milieu. CMS 1 and 3 perhaps. POL-E tend to have high tumor mutational burden, and they tend to respond exquisitely to IO-based therapies. TMB-high is not a good marker overall unless you have POL-E or POL-D or MSI-high. Outside those settings, TMB-high has not panned out for metastatic colorectal cancer as well. So strategies like adding a CTLA-4 inhibitor or anti-VEGF therapy have been developed. I'm showing you here only the randomized phase 2, phase 3 study, understanding there are a lot of studies that were single-arm, single institution, or double institution that I think are less interesting in the sense that they're probably less applicable overall to our overall knowledge. But as you can see, most of these studies were either negative or, I say, borderline positive. LEAP-017 with Lenva Pembro versus standard of care was one of the later studies to be presented and published, which also did not show that Lenva added to Pembro improves outcome versus standard of care. Maybe at the tail end, you see that 10% of patients perhaps having a benefit, and you see that consistently in our Bakshi study with Keb, Beva, Atezo, plus minus atezolizumab or placebo. Again, at tail end, about 10% of the patients seem to have that benefit. You'll see this presented on Sunday at the oral session for colorectal cancer. This was an attempt to essentially enhance the activity of encorafenib cetuximab with nivolumab based on some preclinical and early clinical work. This is a negative study. Unfortunately, it's actually pretty flat negative from what I read from the abstract. We'll see the full presentation. But we see a first combination that essentially led to a positive outcome, and that's with an agent called zanzalintinib with atezolizumab. Now, zanzalintinib is essentially tyrosine kinase inhibitor that hits multiple targets, but the most relevant for essentially immune enhancement is VEGF, of course. So we know that if you target VEGF, you're going to increase the infiltration with T cells and other healthy immune cells, and also allow the bad cells to leave the milieu. MET inhibition does two things, does enhance the milieu and does seem to enhance the activity of PD-1, PD-L1 inhibitors, but also one of the mechanisms of resistance to VEGF inhibitors is actually upregulation of MET, and so that may serve that purpose as well. So Stellar 303 essentially was a study looking at zanzalintinib, atezolizumab versus regorafenib, given at 160 milligrams. This is a patient population that had significant exposure to prior therapy as designed. Dual endpoint of overall survival in the ITT, so everyone, including liver mets and non-liver mets, and then overall survival in the non-liver mets group of patients. So the results of the study in the intent to treat population were positive for survival and PFS. Both were improved, 10.9 versus 9.4, hazard ratio of 0.8, and this was statistically significant, and PFS was also improved by 1.7 months, and this was statistically significant. You can see the curves here. When you look at the 2 years mark, 20% of the patients were still alive on atezolizumab versus 10% on rego. And when we look at the efficacy by key subgroups, I think I want to focus on the liver metastases subgroup. You can see that the hazard ratios are very similar between the two, understanding that the non-liver mets analysis it was interim, and we're going to see hopefully soon the final results. But you see that overall the non-liver mets actually prognostically tend to do better. That's why the numbers, the absolute numbers, look much better, even for regorafenib, 12.7 months, with Zanza plus Atezo, 15.9 months. But regardless of liver versus non-liver mets, it seems that this combination outperforms regorafenib. Now, again, we don't see responses, but a lot of stable disease. Disease control rate was superior with Zanza Atezo versus regorafenib. Now, there are certainly some safety concerns, and it's important to bring those up. So you see more diarrhea. The one thing you see, of course, more with regorafenib is the PPE or HSFR. But pretty much everything else, you can see that certainly a little bit more on the combination arm. Fatigue is asthenia, or fatigue is a little bit more, again, with regorafenib. When you look at essentially those modifications, more so on the Zanza plus Atezo, 61% versus 40%. When looking at adverse events leading to discontinuation of all treatment, it was pretty much the same in both arms. So as we know, the FDA accepted the new drug application for Zanza in combination with Atezo. That doesn't mean an approval of the regimen yet. That means it's moving forward for final assessment. So we'll see if and when this regimen gets approved. So other targets of interest include EGFR and MET bispecifics with an agent called amivantamab. Origami-1 was first to assess doublet chemotherapy plus amivantamab, showing some elements of interest. Now, the MET amplification is known to be a mechanism of resistance for EGFR inhibitors. So the thought here, by combining the two, that you may essentially revert some of the risks of resistance and enhance activity. So early results are interesting. Origami-2 and Origami-3 are looking at essentially first-line and second-line options with adding it to chemotherapy. Breakwater, again, has brought the first-line regorafenib plus cetuximab into the first line with chemotherapy. So we've seen the first results with FOLFOX, and pretty impressive results, I must say. I mean, that doubling of survival outcomes is in this patient population is certainly in colorectal cancer overall, not just in this bad actor, is pretty impressive. We'll see some results on survival and PFS with the FOLFIRI arm in this setting. So this essentially just summarizes the overall landscape of metastatic colorectal cancer and how we think about treating it, subclassified by MSI-high, BRAF 600D, moving oncocytotoxin into first line, RAS mutations, HER2 amplifications, and then in the bottom we have three options right now: rego, fruquintinib, TAS-102 plus minus beva in the refractory setting. We'll see if Zanza plus Atezo gets approved, whether it becomes an addition, and where would it be placed is going to be a point of discussion that we'll have next. Thank you. Okay, so again, going back to the surveys, what first-line treatment would you most likely recommend for a 60-year-old patient who presents with left-sided pan-RAS wild-type, BRAF wild-type, HER2-negative, MSI-high colorectal cancer? So clinically stable versus highly symptomatic. So clinically stable, this is somewhat of a younger patient. Seems like everyone is going for Nivo-Ipi. That's pretty easy. What do you think, Stacey?
I chose Nivo-Ipi in this case, but I think what's important takeaway here is sometimes there's this idea that Nivo-Ipi is going to be, or the immunotherapy in general is going to be slower for response, but when they actually looked at time to response in Keynote 177, they showed it was pretty similar between immunotherapy and chemotherapy. So I think the point to be made here is that immunotherapy is both highly effective and durable, as well as has a more immediate response or in parallel to what you'd see for chemotherapy. So if I think a patient is a candidate for immunotherapy, regardless of their symptoms, I would go ahead and do that.
So, Arvind, clinically stable, let's say Lynch syndrome patient with Lynch syndrome, clinically stable, minimally symptomatic. Is there any scenario in this young patient where you would consider single agent PD-1 inhibitor?
There may be some patients where perhaps we're worried about IO toxicities, but honestly, that probably would be a minority of patients where maybe single agent checkpoint would be better than dual checkpoint. But for most patients, based on the 8HW trial, I would go with dual checkpoint inhibitor.
All right, so what first-line treatment, I don't like when everyone is agreeing on every single thing. What first-line treatment would you most likely recommend for a clinically stable 60-year-old patient who presents, again, left-sided, pan-RAS, wild-type, BRAF mutant, HER2 negative, MSI high, metastatic colorectal? Notice this is a BRAF mutation here in this younger patient. So everyone says Nivo-Ipi. Do we think that in this patient population with BRAF mutations, Nivo-Ipi would be the absolute favorite?
I would say so. I mean, I think even in BRAF mutant patients who are MSI high, does appear that immunotherapy would be more effective than BRAF targeted therapy. But we do have to wait for the CMARC trial to report out whether the combination is better.
So, Stacey, the CMARC trial has a control arm of pembrolizumab, which is not essentially the standard that everyone now here agrees on. So what would make, I'm not going to make you guess about what the results are, but let's say the results are positive. What would make the case for switching to Encositux Pembro versus a Nivo-Ipi in a patient, say, with the same scenario?
I think we just have to do the dreaded cross-trial comparison and look at what we see reported out for nivolumab, ipilimumab, and compare that to the CMARC experimental arm, looking at Pembro with encorafenib cetuximab, and just see if we think we can tell which is better. Because, CMARC is an amazing trial. I don't expect that we are going to then do some kind of 4-drug follow-up study. So I think if it's positive, we'll just have to kind of put the two trials together and make our best estimate.
Okay. So have you used or would you use a ctDNA assay to determine whether to discontinue immune therapy for a patient with metastatic colorectal cancer who is faring well? So all of you said, I have, except Dr. Liu and Dr. Bekaii-Saab. So, Arvind, so you have. What are those instances where you would consider this?
So these would be patients where we've done immunotherapy for a while, year and a half, 2 years, and scans show that there's prolonged stable disease or even complete clinical response, complete radiographic response. And we just need one more data element to confirm that. So that's where ctDNA would come into play and really provide that additional piece of information.
So, Stacey, how about you?
I agree. I think I'd use it in the same way as I talked about for neoadjuvant rectal cancer, where you think someone's in a clinical complete response and you're looking to see if the data seems concordant or discordant. And so I would use it in that setting as I would be clinically planning on discontinuing the therapy and just trying to gather other pieces of information to decide if that's a good or not so good decision.
All right, so a quick question. So for a patient who has stage 2-3 colon cancer, microsatellite stable on surveillance, this is a question from the audience, and MRD turned positive during surveillance, but you don't see any radiographic disease, do you initiate therapy or observe until radiographic progression? And would your answer get influenced by whether patients received adjuvant chemo or not? Arvind.
So if the patient on surveillance has not previously received adjuvant chemotherapy and is MRD positive, then I would have a discussion about starting adjuvant chemotherapy at that point. One of the abstracts from the Galaxy trial will be presented at this meeting, showing that there is benefit to that approach. For patients who've already received adjuvant chemotherapy and are MRD positive and scans are negative, I don't think we have a clear answer about what to do in those patients, especially if they're microsatellite stable. I think that needs to be an involved discussion with the patients and preferably enroll those patients on clinical trials.
So, Stacey, this one for you. Low-risk stage 3 colon cancer, stat post-resection with initial MRD was positive. Now, the patient gets K-Pox for 3 months and then capecitabine monotherapy for another 3 months with a total adjuvant treatment for 6 months. Now, ctDNA turned from positive to negative at this point. And ctDNA then started rising again after completion of adjuvant. So would you, let's say a couple of months later, would you recommend restarting therapy, close monitoring, switching therapy, or any other thought?
So in this scenario, or in anyone who had delayed, like maybe ctDNA positive a year later or whatever during surveillance, I would be getting a full set of scans, typically a CT, chest, abdomen, pelvis. If that came back negative, then I would be looking for follow-up imaging, such as an MR of the abdomen or a PET MR, since we know the highest shed is from the liver, and also the most likely spot of metastasis is from the liver. So I'd be really doing good cross-sectional imaging. And then typically, instead of following them once a year with imaging, I would be doing it every 3 months. But I think the other thing that can come into play is, again, we don't always just have positive negatives. Sometimes we have a quantitative number. So if they come back positive in 0.05 and I don't see anything on my imaging, I'm going to tell them we need to look again in 3 months because there just might not be something that's big enough for us to see. If it comes back positive and it's 3, I'm going to be much more concerned that there is a higher burden of disease somewhere and be maybe thinking about those follow-up scans. But I don't typically initiate systemic therapy based on a biochemical recurrence alone outside of a trial.
Okay, thank you. Great. Love it. So do you believe that there is therapeutic synergy between immune checkpoint inhibitors and multi-kinase inhibitors? I'm going to think that Chris and I are like twins separated at birth. So we say there are not enough available data at this time, but Arvind, do you think that there is enough data to support this? And so what is this based on?
Yeah, I mean, there are compelling preclinical data from mouse models showing that there is synergy between immune checkpoint inhibitors and TKIs, especially in models without liver mets. So that's one piece of data. And the STELLAR trial, as we've seen, there appear to be some clinical benefit. When you look at the curves, there may be a little bit of a tail, maybe starting to form. Is that a biomarker waiting to be discovered? Yeah.
So, Stacey, on that, so Stellar 303 was positive, but there is a number of studies before that that were pretty negative. What do you think is different about Stellar 303?
I think we're learning to subdivide the patient population a little better, notably with or without liver metastases seems to consistently be an important point to really differentiate. I don't know if we totally understand if it's the drug or the patients or our biomarkers. Obviously, it'll be interesting to see how the FDA views all of this, but it's hard because it's a very toxic regimen with some signal, but it's still not curative and does not have the same impressive response on a majority of patients that we see in MSI-high cancers. So I think it's still an ever-moving target. So to me, this answer is yes. I think there's some synergy. Am I ready to start treating every patient in this fashion? No, I'm not.
So, Arvind, then Stellar, I think 313 is moving into the MRD positive adjuvant space. Based on the concerns that Stacey brought about, how comfortable are you with this study for the MRD positive patients?
Yeah, so there should be discussions about kind of adjusting the dose of zanzalintinib to make it more tolerable, especially in the MRD setting where tolerability is key. And Tony, you've led a lot of these efforts for regorafenib, so kind of building on those efforts.
Dose optimization. I'm sorry. Would you like to, do you believe that zanzalintinib atezolizumab will be endorsed? Now, this is speculative, and no one's going to hold you for that. Will be endorsed by the FDA for previously treated metastatic colorectal cancer. So everyone said yes. Dr. Fakih, so Marwan thinks it's not. I'm not going to put you in a situation where you're going to take the side of Dr. Fakih, Marwan, but so what would be a reason for the FDA to say no to a positive study in a refractory setting? Arvind, and then...
So I cannot read Marwan's mind, but I'll try.
I don't think anyone can.
I think he's probably approaching this from the perspective of risk-benefit ratio, the toxicities being higher than regorafenib, which up until now is one of the more toxic drugs we've had for colorectal cancer, and the benefit that we saw was, at least in the overall patient population, was incremental, was not substantial. So perhaps that is the perspective is bringing. Even if the FDA approves, I think it'll be interesting to see how the global authorities look at this. So it'll be interesting to see how this plays out.
So would you like to be able to access zanzalintinib atezolizumab today for your patients with previously treated metastatic colorectal cancer? So Stacey, you said no. Now, you did agree with Marwan on this one, I guess. Everyone said yes. So tell me a little bit of why not.
I think, as Arvind brought up, I'm concerned about the toxicity. I think if it's approved, I sort of hope it's only approved in the non-liver metastasis population, because I think that's the group that's really driving the survival signal. And I think we just maybe need some more robust biomarkers before we expose our patients to a highly toxic combination for minimal improvement. So I still thought it was likely to get approved, and I'm sure I will end up using it at some point if it is approved. But I want the data just to be, I think, looked at even more because of the toxicity profile.
So you're just not eager yet?
I'm not eager yet.
So in what line of therapy do you envision zanza-atezo to be employed? Arvind, before or after fruquintinib? Let me put it this way. I know you led the fruquintinib study, so I'm going to put you on this one.
Yeah, I mean, I was thinking more in terms of before or after TAS-102 plus Bev. So that's why I put in fourth line. Before or after fruquintinib, I think it's up for debate. I think either approach should be fine. But what I'm really intrigued by would be the non-liver met patient population. If there's going to be a significant benefit in that patient population, perhaps that's where you should use zanza-atezo before fruquintinib.
Excellent. Stacey, I'm going to ask you one question, not on this. This came from the audience. This is, and I heard what you said about commit. So can atezo be used in dMMR rectal cancer locally advanced if dostarlimab is not available, or even, I would assume, pembrolizumab, like, say, this came from Pakistan?
So I think as the NCCN guidelines have it, which I know is used here but also used globally, is that all the PD-1 and PD-L1 inhibitors sort of got lumped together. I foreshadow that with the next iteration of the guidelines, we may be moving the PD-L1 inhibitors to a different sort of classification. So if it was atezolizumab or chemotherapy, I'd probably still go with atezolizumab. But if I had the opportunity, and I think in the United States where we have access to PD-1 inhibitors, I would strongly use a PD-1 inhibitor if that was the available drug, and only use the PD-L1 inhibitors when they've been specifically evaluated. And really, again, we're only seeing that strong signal with chemoimmunotherapy, so I'm concerned that the PD-L1 inhibitors by themselves don't have the same efficacy that the PD-1 inhibitors do.
Excellent. Thank you for joining us, and thanks Stacey and Arvind for a wonderful presentation and discussion. Thank you.